Great. Can you guys hear me okay?
Yes.
Great. Well, thank you very much for the kind introduction, Elizabeth. And thank you to all who I've met and those who I haven't met here. It's been a great visit today, and really appreciate the opportunity to come visit, talk to you, and hopefully be able to present some of the exciting field of incretins in older adults. I'm a geriatrician by training. I'm going to say I give this phrase, I eat, live, and breathe older adults. Maybe not eat, but everything I do really professionally and from a community-based standpoint, I really love to focus on the older adult population. So I'm hoping to be able to kind of teach you something and show you a little bit of my work in the latter part. I do speak very quickly. I use my hands, so bear with me, and here we go. Just some funding and disclosures here, and I'm happy to talk about those at any point. So I always love to ground the science in patient care. I initially decided I wanted to go down the medical school route to see patients. But as I was kind of evolving in my career, I realized I really loved scientific inquiry. So I take this even to this day. I'm looking at, say, Mr. Smith, who's in front of me. The things that Mr. Smith cares about. He wants to preserve his health. Importantly, he really cares about physical function and his quality of life. And probably the most important thing is independence. His independence is of critical importance. Anytime I think about science of obesity or science of aging, I think about this because these are three factors. These are three things that are really impacted both in aging and in obesity, and try to always circle back. The science informs clinical practice informs science. That's where I always come from. I'm pretty much on the tailor end of the translational spectrum. So, busy slide, intentionally a busy slide. What I want to share with you here is there's a fat muscle crosstalk. As one ages, one gains adiposity. Usually peaks in the 6th to 7th decade of life. One's muscle mass and muscle strength diminishes after the 3rd to 4th decade of life. Really, I think I shared with Vicky earlier today, it's all downhill from here. Why do I share this? Because in the past, these have been thought of as isolated kind of processes, but we really need to be thinking about these as kind of intertwined. Why? Muscle is a major metabolic organ. We know that muscle mass and strength, sarcopenia, and sarcopenia, I want to just emphasize, is not just muscle mass. It's loss of muscle mass and strength. Really important from a wordsmithing standpoint. But what happens is that as one gains fat, we know inflammation, senescence, lipotoxicity, oxidative stress, all these increase. That affects the muscle, leads to lipotoxicity, and then guess what? You have a vicious cycle, which is a problem. And then you have a lot of changes that occur on the biology front, and I put here just as example the metabolome and proteome, which all then lead to also further ectopic fat deposition. So let me be scientific. This is bad. Not really scientific, but. So let's talk about the incretins, incretin mimetic agents. These are, as we know, the GLP-1s, the GLP-1 GIP medications that if all of you probably are aware of in one capacity or another. What I want to share with you here is these are the kind of two seminal clinical efficacy-based trials that were published. One, and you can see here, the one on the left is semaglutide. You see the drop in weight. I'm going to get this right here. Drop in weight here natters at around the 68-week mark. What is important to note is that when you stop these medications, you will regain weight. And that really tells us that obesity is a chronic disease. Just like hypertension, you stop a medication, blood pressure will go up. So I want you to keep this in mind as I kind of share my talk here, because yes, these medications can lead to profound weight loss. usually between 15 to 20-some%, semaglutide and tirzepatide. And semaglutide for the treatment of obesity is at a fixed dose. For tirzepatide, you can be at 5, 10, or 15 milligrams, and that can be dose adjusted up until then. And there's a dose response effect with those doses. Now, as I promised you, I'm going to be talking about older adults. So here we go. The big question folks ask me, are there differences between younger versus older adults? So I'm going to present two studies. This study here was in looking at A1C, hemoglobin A1C at 40 weeks after initiation. And based on the tirzepatide dose, older adult outcomes were less than that in younger adults, and they're not dose dependent. Now, that's one study. Guess what? Another study showed that it wasn't. So this is a compilation of all the SUSTAIN trials that used semaglutide versus a comparator group. And they actually, when they subdivided and compared under the age of 65 versus older than the age of 65, there were no differences in outcomes of BMI, weight, and A1C. Take home point, we probably can say that they're probably just as efficacious in older adults as younger adults. However, how about cardiovascular events? And this is obviously, we have some data on this, and I'll show you a study in a minute. But when we look at long-term observational studies of these incretins, and this is a retrospective review, you can see a sizable number of observations. There was less incidence of major cardiovascular events and approximately an 8% risk reduction. So what I try to do when I look at these studies, I always love to look at the age distribution and also look at, have they done subgroup analyses on older adults? So when you do the deep dive here demonstrated, well, the hazard ratio was low when compared to the younger older adult, a hazard ratio of 0.67. But look at the 80-plus-year-old, twofold increase. So is there something going on? We need more data, but just to be mindful. And I say that, if you remember those two initial efficacy-based studies, those were not in older adults. Mean age was in the 40s. So those studies were younger adults. This is a retrospective analysis. So you always want to take the study design into consideration. And when you look at, this is another study, age 70 with type 2 diabetes, they actually found significant differences, and that older adults with type 2 diabetes did well, but this is the take-home point I want to bring to you here. Compared to efficacy-based trials, clinical trials, real-world outcomes are lower. So you're not seeing the same effect in real-world observational studies and real-world practice as you do in the efficacy-based trials. So it's probably a little less. Now, I promised you I'd show you a trial that was evaluating more older adults, and this is it. So there were a series of trials that looked at semaglutide use and its impact and its effect on cardiovascular outcomes, specifically in patients with HFpEF, heart failure with preserved ejection fraction. Why am I selecting this study? I'm selecting this study because this is, to my knowledge, the only randomized clinical trial that I'm aware of, well-designed, low risk of bias, that has a mean age of over 65 years old. So I promised you I'd share, I'm doing the deep dive in the older adults. This is one of them. The change in weight you can see here between semaglutide and the placebo arm was 6.4%, much less than what we saw in the efficacy-based trial that I showed earlier, which you're expecting about a 15 to 20% weight loss. Now, the question that always comes up is, in older adults, what is an important factor? I mentioned on that first slide, function. So 6-minute walk test is a marker, it's a test of subaerobic exercise capacity, strongly correlated with VO2 max. They measured it. This is one of the only trials, clinical randomized clinical trials that has measured a functional performance outcome. And that is really important. And the authors said, well, we saw a difference, statistically significant difference. So I always love to be the Debbie Downer. Everybody says to me when I always overly criticize articles, why are you so harsh? You don't want me at a journal club. 14.3 meters is not clinically significant. So let me just share that with you. Usually minimal clinically important differences are range between 30 and 50 meters, depending on the study cohort. However, the thing that I want to bring to your attention is what about quality of life? They measured quality of life using a questionnaire I had never heard before, the Kansas City Cardiomyopathy and Clinical Care Questionnaire. Valid? Yes. Reliable? Yes. Will I take it? Sure. They found a statistically and clinically significant difference. So I feel better. Hopefully I've convinced you to feel better that maybe semaglutide, which led to a 6.4% difference in weight loss, had effects on quality of life. Check. I'd be remiss not to talk about dementia because I'm a geriatrician and we're all worried about our aging population. You may have heard that at the Alzheimer's Association conference at the beginning of December, there was some data that was presented by industry that demonstrated that GLP-1 treatment did not reduce the risk of dementia. There were methodological issues with that. Patient population that they selected was likely not suitable for the outcome, the a priori outcome. So with that in mind, has not been published, but I'm presenting you data here, with observational data, which demonstrates in the One Florida consortium and a meta-analysis of 10 RCTs on GLP-1s. Keep in mind, this is liraglutide. So we don't have the data on sema or tirzepatide right now, but it did show that the risk of incident dementia actually was lower. I share that, more data is needed. Good to think about the relationship between weight loss, fat, muscle, and cognition. Okay, let's revert back. Here we are. What happens with these individuals clinically? I've seen this in my clinical practice where patients are started, then they stop. Why? Adverse events are higher, and they're higher actually in older adults and younger adults. When you ramp up the dose, the ramp up of the dose of both semaglutide and tirzepatide is pretty rapid, and individuals can get significant gastrointestinal issues, nausea, vomiting, constipation, which leads to discontinuation. So the take-home point here, I think there's plenty of data to suggest that adverse events with these medications is much higher in an older adult population. So that actually is important clinically from a translational standpoint because we need to be very mindful when we're prescribing these medications. I wanted to mention physical function again here before we kind of move on. And this is, again, a busy slide, but this looks at the short form 36, which is a marker of quality of life, breaks it up into mental health and physical health components. And the IWQOL, which is an obesity-specific quality of life questionnaire. When they combined all the STEP trials, which are the semaglutide trials, and this is in all comers, so this is younger and older, quality of life and physical, self-reported physical function was improved. You noticed I said self-reported physical function. Okay. So what happens when you stop the medication? You saw, and I presented the first slide deliberately way at the beginning because I wanted to show you the trajectory, but I'm coming back to this now. So when you stop these medications, you will regain weight. But is it all about the weight? It's not all about the weight. It's about function, which we don't have data for, and quality of life, which we have some decent data. But what we know from this study, this is a post hoc analysis that looked at quality of life data post discontinuation. individuals that continue the drug versus those who discontinued the drug. Those who continued the drug still had maintained quality of life based on these reported questionnaires, whereas those who discontinued, actually, their quality of life started reverting back towards the direction of where they were prior.
They don't know.
Yeah. Okay. So this is where I get to say, I really love BioRender if you haven't played around with it. I'm proud of this slide. So this is the shameless self-promotion here. But I want to walk you through this. This is a conceptual model that I've also often used, and I published this with one of our early career investigators who I mentor. But I think it really is, I think it's a telltale. When we think about obesity, we think about one gains weight, right here at the bottom. As one gains weight, we know from clinical trial data, epi data, that physical function diminishes. And obesity-related complications increase. Hypertension, diabetes, high cholesterol, cardiovascular disease. We know from behavioral weight loss interventions, you start losing weight, right? What happens to function? Improves. What happens to complications? They diminish. Now, I think unfortunately, we're in a weight-centric approach. And we need to think about the obesity management, particularly in older adults, a little differently. As one loses weight, we know when you lose weight, you'll lose both fat and you'll lose muscle. How you define that depends on the modality. Are you using CT and MRI, which are gold standard? Are you using DEXA, which measures fat-free mass, which includes muscle? But what you want to do is you want fat loss to exceed muscle loss, and you want to balance that you're maximizing physical function. You want to maximize. What is the sweet spot? So you think about these newer medications. We want to be able to, folks are losing weight, but you want to be able to maximize the physical function without pushing it too much where you develop weight loss-induced sarcopenia. Because you can lose a significant amount of fat, but you can also lose a significant amount of muscle, and that muscle is a problem because it's a strongly metabolic organ and it's key determinant of physical function. So I would love to say we know what we need to do. We don't. We don't know how much is too much. So I wanted to spend a couple minutes on this slide because I think it's really just from a conceptual standpoint. So this term and concept of obesity with sarcopenia or sarcopenic obesity is really important. The terminology for sarcopenia has evolved countless times over the last 30 years. I'm privileged to be part of a consensus that basically says high body fat, low muscle mass, and low muscle strength. And we've done a number of epidemiological studies that have really shown adverse outcomes. The synergy between obesity plus sarcopenia is worse than, that synergy is worse than either of them alone. Picture's 1,000 words. I always love pictures. This is MRI, cross-sectional image of one's quadricep muscle. This is a patient participant without obesity. Whoop. There we go, sorry. Without obesity, but you can still see fat infiltration. This is hyperintense signal. That's still fat. It's normal to have some degree of fat in one's muscle. That's not normal. And this intramuscular fat is what really leads to this vicious cycle of functional decline. This is what you want to try to avoid. So again, plug in for the consensus statement. If you have any interest, let me know. Happy to share this article. So backtracking a little bit, we've talked about some of the changes that occur, but this is really a seminal study by Dennis Villarreal that demonstrated, this was one of the first randomized trials, behavioral weight loss trials, caloric restriction with aerobic and resistance training. And what he found is that when you lose weight, when you engage in these kind of interventions, you will lose lean mass, and this was measured using DEXA. That is normal. Resistant exercise blunts the loss of lean mass. And I think that is key. When we talk about exercise, we really need to be specific in terms of the type of exercise that we're calling out here. Aerobic does not blunt the loss of lean mass. Resistance does. And it's important because he found despite almost a 10% loss in weight as a result of his behavioral weight loss intervention, physical function was much more improved in the combination aerobic resistance, caloric restriction intervention. So you can improve your physical function despite losing lean mass. So key take home, just because you're losing lean mass doesn't necessarily mean you're losing physical function. Okay. I'm going to go a little quick here. Bariatric surgery. We know you lose fat. We know you lose a lot of fat-free mass. And different procedures lead to different amounts, but it's significant. Liraglutide, this is one of the first studies that demonstrated changes in body composition with liraglutide. So I'm kind of going to give you a little bit of a historical perspective here. Approximately 23% of the weight that was lost was fat-free mass using DEXA. You may have heard of the quarter mass rule. Steve Heimsfeld kind of coined this. It's a heuristic. It's based on best kind of guesses rather than hard scientific evidence that approximately a quarter of the weight one loses during behavioral weight loss interventions is fat-free mass. So that's the kind of the threshold that we're dealing with, but we don't have hard data to be able to support that. Now, what data do we have in the newer GLP-1 GIPs? And this is what has made, oh, you're losing weight, you're going to lose muscle. And again, this is DEXA, not muscle, it's fat-free mass. It's really just, the terminology is really important. So this is a Wilding study. Keep in mind, this is not older adults. This was done in a subset of approximately 140 adults who were randomized to either placebo or to semaglutide. And they found that total fat mass diminished, but total lean body mass also, they termed it lean body mass, diminished as well. So approximately 40% of the weight that was lost was fat-free mass, lean body mass. Much higher than that 25% heuristic. Tirzepatide. This was another, again, study. We're thinking about the other medication, very dose dependent. It seems as though tirzepatide has less negative effects on body composition, specifically fat-free mass, than semaglutide. Why? Your guess is as good as mine. We don't know yet.
Is the percentage loss of fat-free mass greater the more a patient loses weight? Is muscle in more danger the more you lose weight?
Yes, that's the thought, but but we don't know. Yeah.
That last slide I thought was because of the one before was because of the huge amount of weight loss in that study.
Right. This is another slide that I want to focus on a little bit here. Locatelli actually really nicely schematic, so I'm not going to take credit for this because I didn't do this. But this is the tirzepatide study. The tirzepatide study demonstrated that your relative change was in favor. So your fat-free mass actually went from approximately 51.8 to 59.2%. Because your fat diminished. So, you have to add to 100%. Let's put this in another way. Individuals lost 23 kilograms of weight. Of that, 17 kilograms was fat, 6 kilograms was fat-free mass. 6 kilograms of fat-free mass amounts to approximately 10 years of skeletal muscle aging. That's a lot. And
70.
Sorry?
In 72 weeks, you've lost as much muscle as you would by the
Now, The thing that we don't know is everybody has a threshold for crossing that that disability threshold, and whether or not we don't know what the muscle quality is in these individuals. Empathy. Yeah, approximately 50%. Yeah, absolutely. And so that's why it's really important to keep the terminology. And I would love to, I'm honest with when I give my talks, I still make mistakes. It's like the obese patient. I've gotten really good at that. It's a patient with obesity. I've been I think I've gotten that. I'm past that, but and I would encourage you. My colleague Carla Prado has written a great article on the terminology and body composition with Steve Heimsfeld last year on the differences and the different compartments. But it's extremely important to be. You need to know the modality as to what is being measured. But this is really important. This is what really worries, at least me as a geriatrician and a clinical trialist, is that you're losing weight. Everybody's at a different threshold. What happens if you cross that threshold? You get into deep trouble. Now, this is supposed to make folks feel better when they did a sub-analysis and they looked at the 65 and up. So font small, I know, but I tried to put that little red circle here. The red circle really shares that, well, guess what? We're all good. There's no difference in changes in, fat-free mass amongst the older adults. Well, let me tell you, the number of individuals, 14 in the tirzepatide arm, 6 in the control arm. You're all scientists here? Enough said. This is another MRI sub-study of SURPASS, sorry. And what they did MRI imaging to look at muscle volume, which is, again, MRI's gold standard. They looked at muscle quad volume, and they looked at muscle intramuscular fat. We know that both diminish with age. So you had a reduction in volume, but you actually had an improvement, a reduction in intramuscular fat as well. But they didn't check and they didn't evaluate muscle function. And that's really what was missing from this study. So a question that often comes up, you have individuals, frailer individuals, who may be near the cusp of that disability threshold, because everybody's disability threshold is a little different. So this is, again, retrospective study. It was done in using the Asian Working Group for Sarcopenia definition. They have a different definition for sarcopenia. And they found that appendicular skeletal muscle index, hand grip strength, both diminished with semaglutide in those with sarcopenia. So this is a problem. This is only the one study that I found that looked specifically in patients with who are categorized as sarcopenia. I'm not saying that we shouldn't be treating these patients with these drugs with individuals with sarcopenia, but it does give you pause as to whether or not they're appropriate candidates. Now, this study came out in November, and I did my best to kind of get this as clear as possible, but so we're stuck with what we got. This is a secondary analysis of the semaglutide and heart failure study that I showed you earlier. And what these authors did is they created a frailty index. And per their frailty index, highlight, underline, bold, their frailty index, they demonstrated that frailty improved and then the degree of frailty diminished with semaglutide treatment. Does that make me feel good? Maybe. The challenge here is, how do they define frailty? And that's a huge interest of mine as a geriatrician, both clinically and research-wise, that there are standardized ways of creating frailty indices. And I would say, again, being the cranky reviewer, in reviewing this paper, there are elements in terms of their methodological process in creating a frailty index that do not follow standards for creating a frailty index. So I say stay tuned. Bone loss. So we've talked about the muscle and the body composition. Let's talk a little bit about bone. Back to Dennis Villarreal's study. His study also looked at bone density, and he found that caloric restriction alone, you lose bone density. Caloric restriction with aerobic exercise, you lose bone density. Caloric restriction with aerobic and resistance, or or just resistance, you still lose, but it's mitigated. So we know that. And we know that too from bariatric surgery. While there's a lot of other pathophysiological processes that occur with bariatric surgery, we know that profound amount of weight leads to challenges and kind of disturbances in the physiology of vitamin D metabolism in particular. So we know that weight loss can lead to changes in bone physiology. So to date, there have been no published trials looking at the impact of semaglutide or tirzepatide on bone. This is the closest that I've been able to find on bone markers. So you're looking at procollagen type 1 and terminal propeptide and the cross-linked C-terminal telepeptide. These are markers of bone metabolism. And with this study demonstrated that semaglutide actually enhanced these, which when you translate that leads to increased bone turnover. So I'm not here to paint a negative picture, but I'm here to we need to open our eyes in certain populations. And I will say to you, my clinical trial, which I'll share with you a little bit later, we have our DSMB is not including, is a behavioral trial, not including patients with osteoporosis and caution with individuals with osteopenia. Although in clinical practice, we don't think about it twice. So metabolic adaptations occur, when you stop therapy. And you get this gain and this rebound in weight. During treatment, your caloric restriction is diminished, your appetite's diminished. This leads to reduction in body weight and energy expenditure. And then once you stop the med, again, your appetite increases, your energy intake increases, you've lost muscle, which is a major metabolic organ. So what happens? The body's pushing you and you end up regaining weight. My friend and colleague, Kristen Beavers, did this great study a couple of years back. This is in the behavioral weight loss. She did a behavioral weight loss in postmenopausal females. It was, I think, a 4 or 5 month RCT. And she found individuals lost weight, they lost fat-free mass, fine. But then they stopped, and then she found in those that regained, for every 1 kilogram of fat that was regained, only 0.12 kilograms of fat-free mass was gained. So remember, during weight loss, it's about the quarter mass rule, right? The flip is not the same. We don't have data on what happens with body composition with incretin therapies when one stops incretin therapy. So it's, again, we're extrapolating what may happen with behavioral weight loss interventions. So now that I've painted a completely negative picture and it's all doom and gloom, what do we do about this? So I just want to very briefly present to you some meta-analyses of what to do. These are lectures in themselves, so I want to be mindful just from a time standpoint. Resistant exercise works in behavioral, likely should be considered here. And I'll show one study in a minute. But there is heterogeneity of the types of exercise, the duration of exercise, the types of patients. And for those of you who haven't seen this, there's a great NIH roundtable that was published, I think, in 2023 that talked about heterogeneity of exercise that I would encourage you if you incorporate that in any of your work mechanistically. So Lundgren and colleagues are really the pioneers, for the lack of a better word, of looking at incretin therapy plus exercise, aerobic and resistance. This is one of the only randomized trials that is available. And they demonstrated after 8-week caloric restriction, they put individuals on liraglutide, and then liraglutide plus exercise or exercise alone. The take home from this study is that exercise, aerobic and resistance plus liraglutide actually led to marginal amounts of weight loss. Liraglutide leads to much less, up to 5% weight loss, up to. So keep that in mind. But it led to preservation of fat-free mass. And that's really, I think, an important component to give some evidence to say of the importance of resistant and aerobic exercise. So this is what I generally recommend to my patients. 30 minutes a day, low, moderate intensity, ideally 150 minutes a week, but I say as much as you can. Anything's better than nothing. Start low, go slow. Big old adage in clinical geriatrics. And I often, if not always, refer individual patients to physical therapy, at least my older adults. Protein always comes up. Well, what about protein? And when you look at the data for protein, it's kind of mixed. It's not as robust as you would like it to be. And, I can share with you, I've put in grants in that have been protein-based grants, and they're like, oh, this is not original. But we really need good randomized trials, and randomized trials that look at protein plus exercise with weight loss. And then throw in the vitamin D just to add, complexity to the mix. It looks like vitamin D plus protein plus exercise are probably the way to go. So I think we talked about this earlier with someone earlier today, adequacy of protein intake. You talk to different people, you'll get different answers. It's all consensus. Now, years ago, you were worried about giving too much protein because of renal insufficiency and the like. I think the standard of care right now is if you're on hemodialysis or if you have stage 5 chronic kidney disease, you need to be mindful of the amount of protein. Stage 4, you can monitor. But generally, try to give the protein during the day and often after exercise, because you've primed the muscle and it allows for protein to be used. Here's the thing, in older adults produce less protein and they metabolize and they degrade protein faster. So that is a rationale for kind of increased protein concentrations. I want to be cognizant that, and I'm not going to go into the definition of malnutrition, but when you lose a precipitous, there is a Venn diagram between persons with sarcopenic obesity and malnutrition. I'm part of a consensus that we're writing about malnutrition in the context of GLP-1s, and really excited about this. But it's something that we need to be mindful because there are a significant number of nutritional deficiencies that need to be addressed. I'm not going to go into this, don't have the time for that, but just want to kind of bring that onto your radar. So this is a slide this is my expert opinion. When I see a patient, a question that always comes up is, who's the ideal patient in my clinic? And I have a number of patients that I'm prescribing these medications, but I'm not giving them to everybody. I generally put an upper limit of 85 years old. Why? Because the epidemiological data and the data after 85 is much less robust. And are they really going to gain the life expectancy and the quality life expectancy? We don't know, but unlikely at that stage of life. There are affordability and access issues. They need to be off all obesogenic medications. This is more clinical, where I look at the med list every time and I'm like, okay, this can cause weight gain, that can cause weight gain, this can cause weight gain. Get them off, switch them around. I generally have the patients see a dietitian if they haven't already seen one. Ensure that they're trying to not calorically reduce their diet, but try to get them to alter the diet quality. And this is where a collaborative team approach really comes into play. And if I have a patient that's already going to the gym 3-4 times a week, that makes me feel a lot better. to be able to prescribe these medications. This is on the right. There you go. Let me turn around. Cautiously in osteopenia and avoid in osteoporosis. And where are they on the sarcopenia trajectory is really important. And this is where doing some office-based measures, which I'm happy to talk about it, after our talk, is really important to be able to see. Are they disabled? How frail are they? Are they going to be able to engage? And are they, if we're going to lose a significant amount of muscle, are we like pushing them below the threshold? So I always like to say, pause before prescribing and ask these questions. And this is where I have this shared decision-making with our patients. Weight loss is profound. These newer medications, the triple agonists that are coming out or will come out and are not FDA approved yet, we're going to be losing, 25, 30, 35% weight, starting to approach that of bariatric surgery. So we need to be mindful. Are they for the right, which patients are they? I think someone mentioned earlier, I think today, and I had a conversation earlier this week, these are not these new medications that are driving the amount of weight are not for those with a BMI of 30. I don't know, that's my personal opinion. But something, we need to be mindful of that. About 40% of the weight loss is fat-free mass. We need more studies. There's no doubt about it. It's like the blind leading the blind here. We have studies on which are underpowered, and we need to be able to kind of better define this. We need data on physical function. We need to move away from a weight-centric approach to a more function-based approach. What's important to the patient? Them sitting and playing with their grandchildren, that's really what is important. We should be targeting that. And it may mean they only need the amount of weight loss of a behavioral intervention rather than 15, 20%. And what we don't have data on are the long-term consequences in these patients. So what are some future research efforts and gaps? This is my kind of what I conceptually think. What are some types of adjunctive interventions? Who's the right candidate? How do we define success? Heterogeneity of treatment response. The responders, non-responders. Why are some people doing better than others? Mechanistic markers. We need to understand these mechanisms. Trial duration. These are medications that are probably going to need to be, individuals are going to need to be on for a long time. What's happening with weight regain? Big unknown. So I'm going to pivot a little bit here in the last, I think I have about 10 minutes or so, to some things that have been of interest to me. I think one older adult is one older adult is one older adult. And this is geriatrics for you. They're a heterogeneous group. Obesity as a chronic disease is a heterogeneous disease. You got heterogeneity plus heterogeneity. Oh boy, you have a lot of heterogeneity here. So you have ways to approach this. This is kind of a way to think about it. We need to be thinking about heterogeneity here. So clinical trials, as we know, are often a homogeneous population. Older adults are often excluded. We need to be thinking about how do we treat and balance the muscle and fat mass loss with heterogeneity and aging and understanding potential harms and potential benefits. And we need to achieve patient-specific goals. So how can we leverage this heterogeneity? That's the key question, and there are ways to do that. This is one study that we just published. It was a small clinical trial that we did of a behavioral weight loss intervention. What I want to bring to your example, these are 4 different measures: VO2 max, 30-second sit to stand, 6-minute walk test, and weight. Blue and red represent responders, non-responders. You can see, pardon? For weight, yeah. You could see all over the place. So which tells you outcomes differ depending on the person. Why? That's what we need to find out to be able to personalize and target treatment. So this is one study that actually demonstrated how well someone does from a response standpoint, and response was defined as weight loss. But if you had a longer duration of diabetes, if you actually had more muscle, you didn't lose as much weight. And that has to do with your muscle being the metabolic organ, as well. Significant amounts of visceral fat. So we need better data on this, and we need to use the clinical trial data to be able to look at predictors of response. This is something that I'm really interested in, something called adaptive trial designs. And I mentioned here traditional RCTs, two-arm RCT, right? Intervention 1, intervention 2. You randomize individuals, and guess what? You look at a delta between those who lost weight, those who didn't lose weight. There are problems with these traditional designs, and particularly in patients who have heterogeneity. What ideally you would like to do is randomize individuals to interventions that actually work for them. So something called a sequential multiple assignment randomized trial, SMART as an abbreviation, has advantages. So you're able to randomize individuals, and if they don't respond, guess what you do? You re-randomize them. So in clinical care, I have someone that does well. If it ain't broke, don't go fixing it. Keep them on the strategy. But if it's broke, what am I going to do on their follow-up visit? I'm going to change the treatment. You can do that methodologically as well. And it allows personalization of treatment, responding to progress. And for those of you who do clinical trials and are worried about recruitment and retention, your dropout rates are much lower in these trials because it gives people who are not responding another chance. So this is a current clinical trial that I'm running of 100. Our target is 180 older adults with obesity over the age of 65. We're randomizing individuals to a health coach behavioral intervention to a more structured dietitian physical therapy-based intervention. And then at 8 weeks, we assess their weight. If they've lost 2.5% of their weight, we deem them an early responder because we know early response predicts distal response. And if they're deemed a non-responder, we re-randomize them to the flip arm. So if they started in a prescriptive arm to a behavioral, or I like to call it the Cadillac arm. And this is what's seen in tertiary care obesity clinics, where you throw it almost like the kitchen sink. Now, this trial was designed, funded right at the cusp of when the meds were available. As I say, we have not had a problem with recruitment. We're still recruiting, and it's being successful. A lot of older adults, and I don't have data to show this right now, but older adults don't want to go on these medications, and they can't afford them. So in some ways, we're lucky. So I don't have results to show, but I wanted to show the design. The other thing I wanted to kind of really mention briefly here is we need to be thinking about targeting the system and not the disease. The traditional way of thinking about processes, hypertension, diabetes, is we're thinking about the disease. Medication 1 treats this disease, medication 2 treats that disease. So you may have heard of the geroscience hypothesis. So this has to do with hallmarks of aging. We know that there are 8 hallmarks of aging, and I'm not going to go through all of them, but these are what we think are leading to, and their interactions thereof lead to the development of chronic disease. So what we're hoping, the geriatric, gerontological world is hoping, is targeting aging processes early in the process of developing these chronic diseases can reduce the risk of chronic disease and geriatric syndrome. We're way off, but there are some really interesting hypotheses. We've done some studies here looking at some markers, IGF-1, some of the interleukins that have demonstrated not only strong correlations with physical changes in physical function measures, but changes in weight. So we know that we can, using interventions can demonstrate a change in some of these biomarkers. We have done some metabolomics work. As I've shared with some here, I don't consider myself by any means a metabolomics expert, and probably a dangerous one at that. But what I'm a firm believer. last couple of slides here, we have a number of new medications, both from a weight loss standpoint, but a muscle preservation standpoint, that I think are really important just to be mindful of. Bimagrumab, trevogrumab, garetosmab, SRK 439. I share these because these are muscle sparing. Bimagrumab is it's an activin type 2 receptor antibody. This is a study that was published a couple of years ago. It's in phase 3 trials right now, but it demonstrated a reduction in fat mass, increase in fat-free mass. We don't know about physical function, though. And remember, I mentioned just because you have changes in muscle or fat-free mass doesn't necessarily mean you have changes in physical function. Enobosarm is another one that is thought to have an impact on muscle and physical function. So this was done in patients with cancer. They did not have a diagnosis of obesity. The phase 2 trials, the abstract was published in last January, I believe, which demonstrated improvements in lean mass, improvements of stair climb as in patients with obesity. So we have what I want to bring to your attention here is we have a number of these different medications that are in phase trials that are likely going to come up to the market and are going to be paired with some of these incretin medications and hopefully counter some of the effects. So like I said, not all doom gloom. There's some excitement, and the science of obesity and body composition is really, it's escalating at a rapid pace. And just, I want to obviously thank my research team and my funded collaborators. And thank you very much for your time. I know it's at the end of the day and probably everybody's tired. So thank you.
That was fantastic. Thank you. I really enjoyed it. Maybe two quick questions. The first one is, I appreciated your smart design, incremental design. So do you expect that individuals who are non-responsive in terms of weight loss, treatment A, would also be non-responsive to treatment B, or is that
great question. So not necessarily. So the question is that people that are non-responsive to treatment A, will they be unresponsive to treatment B? So this is where, when you're designing an intervention, you need to understand, or not understand, but you need to be mindful of the behavioral model. So the behavioral model of the health coach is targeting different constructs than the behavioral model of the dietitian physical therapist. So it's targeting different behavioral aspects. This is behavioral intervention, right? So no. Now, one thing I didn't mention is that what we're also hoping to do is, once we finish the trial, we'll be able to create, using machine learning, to create an algorithm that identifies the optimal weight loss sequence for the person with given characteristics. So that's that's our aim too.
Sarcopenia.
Yeah.
Weight, muscle mass, and muscle strength. How do you assess that?
You can't. You cannot. So you can't, using the standardized definitions. You cannot, unless you have access to a DEXA, access to bioelectrical impedance, or if you have a lot of time and money on your hands, you do CT and MRI, and you have algorithms. So what do I do? First step is screening. So there are questionnaires that we ask. There's there's something called the SARC-F, which is a 4-question screener for sarcopenia. It's actually, diagnostic accuracy is high to identify persons with sarcopenia, but it's not used as a diagnostic criterion. So the first step is we ask them, I do a 30-second sit to stand, or I do a time get up and go, which are 2 performance measures. And if they can do that, then we're done. That's like the first step. Ideally, you would want to measure body composition as well. But unfortunately, unless someone's going to pay to do that and get clinicians reimbursed, it's not going to happen.
Showing is that you're using DEXA, you're talking about fat free mass. You're not putting bone in the same image. And I'm sitting there thinking, well, if fat free mass goes down, bone should go down.
Yep.
Maybe it's parallel in approach.
So part of it is me showing the story, but you're absolutely right. You know, the degree of bone loss is not the same as that in muscle, and it's usually it lags. So we don't have the data for that to say, you know, we don't have a heuristic for that, for instance, unfortunately. Yeah,
Yeah.
that's yeah. So
Body,
Yeah.
you know, you don't want that.
right. And there is a group, particularly there's one at McGill that is looking at osteosarcopenic obesity, but you got to be able to measure all this, and there's a huge problem measurement issue here, and different definitions that have not. And this is one of the things that some of these the consortiums were trying to harmonize these definitions. So because they, you know, if you're not talking the same language, you know, how can you advance the science?
Probably the same issue with the best friend, but what about cardiac muscle and the relationship with cardiac fat?
Yep.
And cardiac function, they have had improvement due to, you know,
Loss of ectopic fat or a cardiac epicardial fat, for instance. So my understanding is cardiac muscle is preserved because you're looking at skeletal muscle versus, you know, cardiac muscle. So the composition is slightly different. But if I remember, I think I have come across an article that looked at epicardial fat has diminished. There's no doubt because ectopic fat is diminished throughout the body, but cardiac muscle is preserved and ejection fraction is actually improved. Mm-hmm.
And then now they're having nausea, they're vomiting, they want to keep
Yeah.
that. So can you speak a little bit to that? Because that to me is a concern when sounds interesting.
Yep.
Then we're getting a drug that further reduces.
So there's two things to that. One, if you want to be a purist, how do you define malnutrition? And the Global Leadership Initiative for Malnutrition has a standardized definition for that. I will gladly say that I have never seen that implemented into clinical practice here in the United States. The Europeans do that all the time in their nutrition clinics. So, but when I think about malnutrition, when I'm having a conversation with a patient, they're not eating, they're losing weight, they're feeling weak, their significant other says, yeah, they're not even having canned soup, you know, check their vitamin D levels, they're low, they start becoming anemic, you know, all these other peripheral factors. So this is where it's important, I feel, again, this is just my opinion, having structured lifestyle interventions in tandem with these medications. I worry that just prescribing the med like we are with blood pressure these days and off the patient goes is not the right thing, particularly in older adults. So having a multidisciplinary approach is of critical importance. One thing I didn't mention, I actually bring patients back. When I start them, I'm actually starting them like on starter dose of sema, 2.5 of tirzepatide, and I keep them on that for 2 months and I bring them back in 2 months. Yeah, I'm very cautious. Yeah. Yeah.
Thank you for your data you presented. That you partially started increasing intervention while already being in 60+ age group. Any thoughts on how individuals in their 50s will live in 10 or 20 years on in terms of muscle function?
Yeah, that's a great question. And the short response to that is when you're starting at a higher level. So the hope is that you're able to kind of flatten the trajectory over time. That's the hope. Do I have data to support that? I don't. So that pure speculation.
is happening to insulin sensitivity or resistance in the residual muscle of those patients a treatment-based drug?
So yeah, so we know from data that insulin resistance, diminishes, like your insulin sensitivity improves over time, over with these medications. So just for all of you to be aware, these medications were initially designed for the treatment of diabetes, and then it was like, oh, folks are losing weight. And then they kind of rebranded it, and then as part of FDA, that wasn't the original indication, but then they had to rebrand it and do trials specifically for obesity. Thank you very much, everybody.